Welcome in, everybody. So picture this. You are standing in a dimly lit, totally quiet pediatric recovery room.
Sounds like the start of a nursing shift, honestly.
Right, and your post-op tonsillectomy patient is sleeping soundly. You look at the monitors and everything is completely fine. Vitals are stable, but you notice they're swallowing.
Oh, yep.
Just a lot of, subtle, repetitive gulping in their sleep. Now, most people would just brush that off as a weird sleep quirk, but you're about to hit the call bell and initiate an emergency response because you know that subtle swallow means blood is actively pouring down the back of their throat.
It's terrifying how quiet an emergency can be in pediatrics.
Exactly. And that is the reality of pediatric nursing. The stakes are just incredibly high, the signs are shockingly subtle, and your margin for error when dealing with a child's airway is, well, practically zero.
Yeah.
Which brings us to your specific mission today. You, the listener, are staring down your ATI RN Pediatric Nursing Proctored exam, and you need to conquer pediatric respiratory disorders. Consider this your strategic, high-yield deep dive into those exact study materials.
And we are going to completely bypass the dry textbook table of contents approach today. I mean, nobody needs me to just read bullet points. We are mapping out the clinical reality, moving logically from basic airway support right through the chaos of acute infections, and finally into the lifelong management of chronic respiratory diseases.
Okay, let's unpack this. Because the fundamental rule, like the core physiological concept that governs every single pediatric respiratory issue you'll see on this exam, is this. Children are not just mini-adults.
Right. You really can't just take adult pathophysiology and scale it down by 50%. It just doesn't work that way.
No, it doesn't. And why is that?
Well, a child's respiratory tract is just anatomically distinct. Their airways are incredibly short and aggressively narrow. I mean, in a full-grown adult, the airway is wide enough that a little minor swelling is just an annoyance.
Just a scratchy throat.
Exactly.
Yeah.
But in an infant, a single millimeter of edema can decrease the airway radius by half, which astronomically increases airway resistance.
Which means an infection in the upper airway doesn't have a long protective journey before it becomes a dangerous lower airway infection. It is a straight shot down. Studying pediatric respiratory care is honestly like learning a completely new language.
That's a great way to put it.
Yeah, because the vocabulary used, the vital signs you accept as normal, the interventions you deploy, they all shift entirely depending on the developmental age of the child.
Absolutely. And before we can even look at specific diseases attacking the airway, we really have to look at the tools used to assess and maintain it. Because of that short, narrow anatomy we just talked about, your baseline assessment skills have to be totally flawless. Let's look at pulse oximetry, for example.
Oh, the numbers here are so critical. Because in the adult world, an O2 sat of 92 might just buy you a nasal cannula and like a brief chart note.
Yeah, nobody's panicking over a 92 in an adult COPD patient.
Right. But the ATI text specifically notes that for a pediatric patient, an SiO2 of less than 86% isn't just low. It is a life-threatening, code blue level emergency.
It's a massive red flag. And you also have to consider the physical anatomy when you're getting that reading. You place the sensor probe on a dry site with adequate circulation, a finger, a toe, an earlobe, or maybe wrapped around the foot of an infant.
But the vital nursing intervention that gets tested constantly, like all the time, is moving that probe every 48 hours.
Yes. Why is that so crucial?
Well, I'm thinking about the reality of an infant's skin. It's paper thin, incredibly delicate, and their peripheral perfusion can drop the literal second they get cold. If you leave a tightly clipped glowing sensor in one spot for too long, you are going to completely occlude the microcapillaries. You're risking pressure necrosis.
Exactly. The tissue literally breaks down and dies. You might be saving the airway, but causing a permanent physical deformity on their foot or finger. And speaking of dropping perfusion, when those oxygen levels do fall, we're dealing with hypoxemia. But hypoxemia looks drastically different depending on how long the child has been fighting it.
The early signs are incredibly loud. The body is in a state of sympathetic panic. You see tachypnea as the lungs try to pull in more air, tachycardia as the heart tries to pump whatever oxygen is left, plus severe restlessness and nasal flaring.
Right. The kid looks agitated and panicked. The heart and lungs are just pulling from every metabolic reserve they have. But the late signs of hypoxemia are honestly terrifying because all those reserves are gone.
The body is just completely exhausted at that point.
Totally exhausted. The heart rate plummets and bradycardia. The child enters a stupor, and you see cyanosis, that scary blue discoloration.
So when a restless, thrashing toddler suddenly becomes incredibly quiet, still, and lethargic, You aren't seeing a clinical improvement.
No, absolutely not. You are watching them crash.
That distinction alone will save lives on the floor, and it will definitely earn you points on the exam. Now, switching gears a bit to get medication directly into those reactive airways, we rely on inhalation therapy. The main tools are metered dose inhalers, or MDIs, and dry powder inhalers, DPIs, and the mechanical preparation for each is completely opposite.
Right, they work completely differently. An MDI uses a chemical propellant to shoot the liquid medicine out. So you absolutely must shake the MDI 5 to 6 times before use to mix the medication with that propellant.
But a DPI is just pure, finely milled powder sitting in a tiny blister pack inside the device.
Yeah, so if you shake a DPI, you scatter that precisely measured power right out of the loading chamber and into the plastic casing. The dose is completely ruined.
And taking that a step further, if either of these inhalers contains a corticosteroid, which we use to suppress chronic airway inflammation, you have to have the child rinse their mouth and spit the water out afterward.
Very important step. Because corticosteroids suppress the immune system.
Exactly. If that steroid residue just sits on the oral mucosa all day, the local immune defenses in the mouth are wiped out. That creates a perfect environment for an opportunistic fungal infection like thrush to just coat their tongue and throat. Now, I have to bring up the physical reality of giving an MDI to a 2-year-old.
Good luck with that.
Right. You're asking a panicked toddler to perfectly coordinate a deep, slow breath at the exact millisecond you press the canister.
Yeah.
That is physically impossible.
We completely bypass that impossibility by using a spacer.
I always picture a spacer like an airlock on a spaceship, or a holding chamber.
Well, that's a good visual.
Yeah, you fire the medication from the MDI into this clear plastic tube, and a one-way valve traps the mist inside. The child doesn't need perfect timing anymore. They can just put their mouth on the other end and take 3 or 4 normal tidal breaths to pull the suspended medicine into their lungs at their own pace.
It's a really elegant mechanical solution. Now, if the child can't clear their own airway, we have to physically remove the obstruction through suctioning. But the rules here are notoriously strict because the suction catheter is completely non-selective. It removes life-saving oxygen just as efficiently as it removes mucus.
Right. For an infant, you limit suction time to less than 5 seconds. For a child, less than 10 seconds. And you have to allow 30 to 60 seconds of rest between passes. Less than 5 seconds. To understand why that is so fiercely tested, just try holding your own breath while frantically sprinting up a flight of stairs.
Oh, man. That sounds awful.
It is. Your oxygen demand is spiking because of the physical distress, but you have zero intake. An infant's oxygen saturation drops with terrifying speed during a suction pass.
Which is why you have to be so fast. Now, for deeper, thicker mucus that a regular suction catheter just can't reach, we use chest physiotherapy, or CPT. This uses manual percussion on the chest wall and gravity to literally vibrate and break up secretions deep in the lung lobes. But timing is the primary nursing consideration here. You schedule these treatments 1 hour before meals or at least 1 hour after meals.
Because if you lay a baby at a downward angle and start rhythmically percussing on their chest right after they just chugged a full bottle of formula.
Yeah, they are going to vomit.
And because they are laying down and already struggling to breathe, they are going to aspirate that vomit straight into their lungs. You would be trading a simple mucus plug for aspiration pneumonia.
You solve one respiratory problem and instantly create a much deadlier one. Not ideal.
So we've established the baseline. We know how to clear and support a compromised airway. But what happens when that airway is actively under attack by pathogens? Let's transition into Chapter 17, Acute Infections, contrasting upper airway blockages with lower airway congestion. Let's start high in the throat with tonsillitis.
Right. The tonsils are essentially lymph tissue designed to filter pathogens. But when they get overwhelmed and infected, they swell dramatically. Sometimes they even touch in the midline what we call kissing tonsils.
Yikes.
Yeah, it's not great. Often, the definitive treatment is a surgical tonsillectomy. And your absolute primary nursing focus post-op is monitoring for hemorrhage.
Which brings us right back to that sleeping child in our intro. I'm still amazed by that, by the way. A postoperative hemorrhage in a child doesn't look like a dramatic horror movie scene. Blood is trickling down the back of their throat, and their natural unconscious reflex is just to swallow it.
They don't even wake up most of the time.
Spotting that subtle, frequent swallowing cue is the literal difference between catching a bleed early and having a child aspirate on their own blood. It's crazy.
You also have to aggressively protect that fragile surgical site through their diet. The absolute hardest rule. No straws.
Creating negative suction to pull liquid up a straw, puts immense pressure on the back of the throat. It can rip the fresh scabs right off the tonsil beds. And you also restrict any red or brown fluids like cherry popsicles or chocolate milk.
Yep, because if that child does suddenly vomit, you need to know instantly if you are looking at digested fruit juice or a massive active hemorrhage.
Staying in the upper airway, we have to look at bacterial epiglottitis. This is a true drop-everything medical emergency. The epiglottis is the tiny cartilaginous flap that covers the windpipe when you swallow. When it becomes wildly inflamed by a bacterial infection, it swells to the point of completely occluding the trachea.
The classic presentation is terrifying. You see an absence of a cough, excessive drooling because it hurts too much to swallow their own saliva, extreme agitation, and the child sitting up in a tripod position.
They lean forward, hands braced on their knees with their chin thrust out. They are physically trying to manipulate their own anatomy to pry their airway open.
Exactly. And here's the absolute golden rule highlighted in literally every pediatric text. If you suspect epiglottitis, never, ever put a tongue blade or a throat swab in their mouth.
The physical stimulation of a wooden tongue depressor touching the back of the throat can cause that highly reactive, inflamed epiglottal tissue to immediately spasm. You'll completely, irreversibly seal off whatever tiny sliver of an airway they had left. You don't assess the throat, you secure intubation equipment and call anesthesia immediately.
We contrast that sheer panic with croup, or acute laryngotracheal bronchitis. This is also an upper airway infection, but the hallmark is a distinct, harsh, barky cough that sounds exactly like a barking seal.
Oh, it's such a distinct sound.
It really is. And what's fascinating here is how you can pinpoint the exact location of the infection just by listening to the acoustics of the child's breathing. With upper airway issues like epiglottitis or croup, the blockage is high up in the narrowest part of the trachea. So you hear stridor, a harsh, high-pitched, vibrating sound on inspiration as air forces its way past the swollen vocal cords.
But if we move anatomically downward to the lower airway, to the microscopic bronchioles, we see bronchiolitis, which is almost always caused by RSV respiratory syncytial virus. Now, the infection is deep in the lungs. You don't hear stridor up high. You hear wheezing on expiration as air gets trapped behind inflamed, mucus-filled bronchial passages.
And because the air is trapped, the child has to work incredibly hard to breathe. You see retractions.
Right. Think of sucking on a thick milkshake through a really flimsy paper straw. Because the fluid is so thick and the suction is so strong, the paper straw violently caves in on itself. That's exactly what a child's pliable chest wall is doing during retractions. The skin and muscles sink in around the ribs and collarbones because they are generating massive negative pressure, trying to pull air through mucus-plugged lungs.
RSV produces copious, incredibly thick secretions. The lungs are essentially filling with cellular glue. But unlike other respiratory conditions, the ATI text explicitly notes that chest physiotherapy and bronchodilators are generally not recommended for RSV bronchiolitis.
Which feels completely counterintuitive until you look at the mechanism. RSV doesn't cause the smooth muscle spasms that are bronchodilators designed to relax. It causes cellular debris and dead mucosal cells to physically plug the tiny tubes. A bronchodilator does nothing for a physical debris plug.
Right, it won't clear the glue.
Exactly. The management is entirely supportive, maintaining oxygen saturation and intensely, frequently suctioning out all that mucus until the child's immune system clears the virus.
So acute infections are temporary invaders. The virus or bacteria is the enemy. But what happens when the child's own airway architecture becomes the enemy? That brings us to Chapter 18, asthma, which represents a major shift from a pathogen-driven illness to a chronic inflammatory disorder.
Asthma is characterized by intermittent, reversible airway obstruction. Let's talk mechanics for a second. Asthma is driven by triggers, allergens, cold air, pet dander, or exercise. When a child with asthma inhales a trigger, it causes mast cells in the lining of the lungs to degranulate, dumping massive amounts of histamines and leukotrienes into the surrounding tissue.
And those chemicals launch a two-front attack. First, they cause the smooth muscles wrapping around the outside of the bronchioles to violently constrict and spasm. Second, they trigger massive inflammation and rapid mucus production on the inside of the airway. The tube gets physically squeezed from the outside while simultaneously swelling shut on the inside.
When a child has an attack that is prolonged, life-threatening, and completely unresponsive to standard rescue treatments, that is called status asthmaticus. That's an ICU admission. You need IV access for systemic steroids, continuous nebulizer treatments, and you are prepping for rapid intubation.
Scary situation.
Extremely. To prevent a child from ever reaching that point, we rely on a strict, two-tiered medication strategy.
You must heavily differentiate between rescue and maintenance medications. Albuterol is a short-acting beta agonist. It's the rescue inhaler. It rapidly forces those constricting smooth muscles to relax, opening the tube. You also use it prophylactically right before exercise to prevent the spasm from starting.
But albuterol does absolutely nothing to fix the underlying chronic inflammation inside the tube. For that, you use corticosteroids. Those are maintenance meds used every single day, regardless of how the child feels, to suppress the immune response and prevent attacks from happening in the first place.
And to monitor how well that daily maintenance plan is working, kids use peak flow meters at home. The teaching steps for the peak flow meter are highly testable because proper technique is the only way to get accurate data.
Right.
The child must stand up straight to fully expand the diaphragm, ensure the sliding marker is set to 0. Then, they take a deep breath and blow out into the mouthpiece as hard and as fast as humanly possible. They repeat this 3 times, and you record the highest number, not the average.
So what does this all mean? Like, why throw out the average? I like to think of it like the high striker strongman game at a carnival where you swing the giant mallet to ring the bell.
Oh, I love that game.
Me too. But if you swing 3 times, and one of your swings is just a glancing blow because you slipped, you don't care about the average of your swings. You only care about your absolute best, strongest hit, because that proves your true maximum strength.
That's a perfect analogy.
Thanks. The peak flow meter is exactly the same. It's a test of pure mechanical capacity. A low average might just mean they cough during one attempt. You only care about the maximum physical capacity of those lungs on that specific day.
Now, asthma obstructs the airway through reversible inflammation and muscle constriction. But our final clinical focus today, cystic fibrosis from Chapter 19, looks at an obstruction of a totally different, irreversible nature.
CF obstructs the airways with incredibly thick, tenacious, viscous mucus due to an inherited genetic mutation. Both parents must carry the recessive trait for the child to have CF, and the very first sign of this disease often happens just hours after birth. It's called meconium ileus. The newborn's first stool is so thick and sticky that it creates a total bowel obstruction.
It's heartbreaking, but very telling. To confirm the diagnosis later, we use the sweat chloride test. The genetic defect in CF prevents chloride from being reabsorbed into the sweat ducts, meaning the child's sweat is incredibly noticeably salty.
So what are the numbers for that test?
For infants under 3 months, a chloride level greater than 40 milliequivalents per liter is diagnostic. For all other children, it's greater than 60.
Got it. For respiratory management, CF patients use a fascinating aerosol medication called Dornase alpha. It's an enzyme that literally acts like molecular scissors. It chops up the extracellular DNA left behind by dead white blood cells in the mucus, rapidly decreasing the viscosity so the child can actually cough that thick sludge out.
It's an amazing drug.
But here is the massive irony for a nursing student. You open the textbook thinking you're studying a respiratory disorder, but half your exam questions are going to be about digestion, nutrition, and, well, poop.
It's true. But if we connect this to the bigger picture, the pathology makes perfect sense. The CF mutation affects all exocrine glands in the body, not just the lungs. The exact same defect that creates thick mucus in the respiratory tract, trapping bacteria and causing endless pneumonias, also creates thick, cement-like mucus in the pancreas.
Ah, right.
This blocks the pancreatic ducts, meaning the body's natural digestive enzymes can never reach the small intestine.
Think about what that means for a meal. The child eats a cheeseburger, but they literally lack the chemical tools in their gut to break down or absorb the fats or proteins. The food just passes right through. That leads to steatorrhea, large, frothy, extremely foul-smelling stools that are quite literally full of undigested fat.
To survive and actually grow, CF patients require intense, lifelong gastrointestinal management. They must take artificial pancreatic enzymes, specifically pancrelipase, with every single meal and snack. The rule is simple. If they eat, they take the enzymes.
But here is a critical teaching point for the exam. You can open the capsule and sprinkle the pancrelipase beads onto soft food, like applesauce, but you can never sprinkle them onto hot foods. The heat will denature and destroy the enzymes before they even reach the stomach.
Right, you're just giving them useless powder at that point.
Exactly. And because they constantly struggle to absorb nutrients, their diet looks completely different from a normal child's. They need a high-protein, incredibly high-calorie diet.
And we have to specifically address vitamin supplementation. CF patients require massive supplementation of vitamins A, D, E, and K.
Why those specific 4? Because A, D, E, and K are fat-soluble vitamins. Since the CF patient cannot digest or absorb fat due to the blocked pancreas, those vital vitamins are just flushed right out of the body along with the fat in their staturia.
Mm.
If you don't aggressively supplement them in a water-soluble form, the child will become severely malnourished, even if they are eating thousands of calories a day.
The endocrine system is heavily impacted as well. Over the years, the thick mucus and chronic inflammation in the pancreas actually destroy the beta cells, the cells that manufacture insulin. This causes cystic fibrosis-related diabetes, or CFRD.
And the key here is that CFRD requires actual insulin injections. Oral glycemic medications, which usually work by stimulating the pancreas to release more insulin, simply are not effective because the beta cells are dead. You really have to view cystic fibrosis not just as a lung disease, but as a total body exocrine failure.
We have covered a massive amount of clinical ground today. If you take nothing else away, remember how delicate this anatomy is and the mechanisms driving your interventions. Respect the strict suctioning times 5 seconds for an infant because you know how fast their oxygen plummets.
Watch for the subtle, frequent swallowing of a tonsil hemorrhage in a sleeping child. And remember the absolute no tongue blade rule if you suspect the airway spasming panic of epiglottitis.
When you're testing an asthma patient's mechanical lung capacity, always record the highest peak flow score out of 3 attempts.
And remember that treating cystic fibrosis is just as much about managing the GI tract with pancretopase and replacing fat-soluble vitamins as it is about using Dornase alpha to clear the lungs.
Mastering these nuanced differences isn't just about passing the ATI Proctored exam. It's about becoming the nurse who catches a subtle change in a patient's baseline before it becomes a code blue. It's about knowing the why behind the protocol.
Before we wrap up this deep dive, I want to leave you with one final, fascinating detail from the source material to think about. When a pediatric patient's airway is so compromised that they need a surgical tracheostomy, the pediatric tract tubes aren't just scaled-down, rigid adult tubes. They're made of highly specialized materials, like silastic.
Oh, this is so cool.
Right? When you insert a silastic tube, it is firm enough to maintain the airway. But as it sits in the trachea, it literally softens as it absorbs the child's body temperature. This allows it to gently mold, bend, and shape itself to the exact unique contour of that specific child's throat. Think about that as you study. In pediatric nursing, the child's own physiology and body heat actually become part of how the medical device functions. The modern medical approach isn't about forcing the fragile child to adapt to the medicine. It's about the medicine dynamically adapting to the child. Keep that perspective with you as you prep for your exam. You've got this. Good luck.